welcome guys, welcome back to another video. My name is Amir and I'm a third year medical student at the Govt University. I'm currently in my ophthalmology rotation and today I am joined with Fatima. Fatima, do you want to introduce yourself?
Hi! I forgot who am I?
Fatima Tibgram.
Yeah, I am Tibgram. That's how many people know me as, but I'm a final year at SMC and I'm currently doing a pediatric elective at AKU during my summer vacation.
Yep. So she's from JSMU, that's a government university. I'm from AKU, it's a private university. So we thought, we were like, okay, we have a good opportunity. Yeah, let's have a chat. Let's make a video about, because we get a lot of DMs, like exposure and all of that, comparing government and private universities. So we're like, okay, this is a perfect opportunity to talk about these things, right? So we're going to talk about the core essential differences and not necessarily the differences only, similarities as well between an outpatient clinic, a consulting clinic in a private setup and government setup. And before we begin with the video, I just want to emphasize how this is a very biased, generalized statement. I'm only from one university. I've been doing this for not too long. She's from one university. She's been here at AKU for a few weeks now. So it's going to be very biased, but you can take this with a grain of salt and yeah, enjoy the video. When a student goes to a medical university, they're there to obviously learn. And there's two ways you learn, right? The first one is when a teacher teaches you, and second is when you see a patient and learn from the pathology, right? So let's first talk about a teacher, a doctor teaching students. So what has your experience been like?
We did it, so first 2 years, so it changes every year, right? So what I say right now is not going to be the same for the SMC or like, you know, the Dow kids currently in first and second year, because every year they change everything. So for us, the first few years were entirely, you know, very theoretical, very like, you know, just bulldozing you with information at like very fast rates and all that. Half the time we didn't even understand everything, and then immediately we went to third year. Now the thing in my case was that we went to third year, we did 2-3 rotations, and then the COVID pandemic happened, and then everything else was just COVID hawale, you know, everything was just in that weird phase where you went and you did some stuff and then you came back and you were just entirely confused all the time. So there were just two things, mainly one thing we focused on, which was history taking.
Okay.
And we just made sure that we did that during the day. Like if during the day you're putting on like so much PPE and everything and you're going to a hospital in a government setup, the least you can do is take a proper history and then come back. Like don't come back empty handed. Like we have this one professor, she goes like, "Aayo to patthar bhi leke chale jao." That's the only thing we focused on in third year. We didn't get any diagnosis, we couldn't understand anything, you know, just history bhi ghar aa gaya. Fourth year was a little different. Again, there were lockdowns beach mein, but even then we tried our best to do examinations and histories, and it was definitely heavier. Like every ward wanted you to submit at least 10 histories per ward, and so I used to write them all down myself. Like people have a habit of copying, but I did all of them myself. So, and I went to all the OPDs because when you were in COVID, you realized how important this was. When we were in COVID and we were trying to study everything online, and we were trying to study everything online, but then we realized how important it was to actually physically see a patient, because like something like dyspnea didn't make sense until you actually saw dyspnea. You're like, oh, that's dyspnea. And like tachycardia, palpitations, you know, when a patient tells you a symptom versus a clinical finding, we didn't know how to separate those two things. Like it's very difficult to do that. Currently, the first and second years actually take histories in SMC. So they
on
go
real
to,
patients or
on real patients. They go to
JPMC.
They go to JPMC. They take histories and they come and they present that case in class. So I would say that the current students, they know what they're doing when they take a history.
That's great. Okay, but like, okay, what about in a clinic? You're in a clinic. How much does a consultant, does your professor, a teacher, how much does a resident teach you?
Alright, so in JPMC, mostly it's like R3s, R4s who are handling students. Consultants do not have the time in a government setup because of serious understaffing issues and also because of lack of trained faculty. And they will come to you in a lecture hall or like in a class situation. Like lecture hall में फिर professor या surgeon आएंगे वहाँ पूरी बात होगी. And then over there they do a pretty decent job. At least I don't really hate any of my professors. I think they're all decent, and anybody sleeping in their class is just being lazy. But other than that, in clinics, mainly it's the residents who you're with. So in JPMC, what you have is this setup where there's a very big OPD, like it's a very expansive area.
Yeah.
So in the middle, you have all these cubicles. So ideally, a medical student should stand in at least one cubicle and just see whatever's happening there, like whatever patient's coming in. So usually what happens, the cubicle ke bahar, there's like a line of patients and they go to that particular place. So if there's a case that's very complicated, the residents hold that case and then they show it to a consultant later. The consultants come for like 1 hour during the OPD. You can stand in the consultant room, usually fourth or final year stand in consultant rooms so that they can understand you. But they will not teach you things until you don't ask them. So the best thing that some of my juniors do and we do is that we go to the line of patients and we just start asking them, what is your presenting complaint, what was the history, थोड़ी सी HOPC ली, थोड़ी सी और significant बातें पूछी, ठीक है, उनकी slip पे लिख दिया, and then we take that patient inside and we present it. And then we present, and then the resident goes like, oh, ये बताओ, and then the resident does it. And then we ask it, so what if this is that disease, what if this is that disease, yeah. Sometimes residents will not discuss it if they feel the case is like either too complicated for you or they'll be like, this is not up to your level or whatnot. If some doctor says this is not up to your level, just don't ask any more questions because then in JPMC you see so many rare cases that it gets very difficult to understand. The other thing you can do is if patients come with like this huge thick file of reports, you can go through them. Like so when I was doing the internal med rotation, I was in the OPD and वहाँ पे we saw this one case and उसके अंदर इतनी उसकी वो detailed reporting थी. It was just one after the other. I went through all of them. I was like, what is going on in this patient? And then the consultant was like, okay, so what did you see in this? Okay, so this patient has hepatosplenomegaly. So क्या देखा? LFTs, deranged. Okay, bilirubin, खराब. ठीक है, ये भी खराब. अच्छा, what about the iron profile? What if he has a hemochromatosis? अच्छा, वो भी सही है. अच्छा, वो भी सही. फिर क्या है इससे? Turns out he had cryptogenic cirrhosis. Which means there's no cause.
Okay.
So you went through all those files. I was like, what is that? And she's like, नहीं पता कोई बात नहीं, पढ़ के आना. And then I wrote it down and then I went home and searched it up. Like, I was like, is this rare? She's like, we have cases. Like, ajeeb flex silent. So, but that was just one case that I extensively looked at.
Yeah.
And उसमें भी सारे liver hepatology सारी पढ़ ली because that patient was just like the ideal patient to study on.
Yeah.
So that's something I've seen in JPM.
So,
one patient will teach you everything.
Yeah. So like AQ mein, how the system works is there's one consultant you're rotating with. You're usually with either one or two other clinical partners. So there's maximum 3 or maximum maybe, I don't know, perhaps 4 as well with one doctor. You're rotating with him, you're doing whatever.
People in one group and
Yeah,
then
so
you
that's-
have to divide on your own. They don't divide you yourself. You have to divide on your own.
So the ratio is 1 to 4. AQ mein, it's 1 to 40 over there. All right. So there's that, and obviously there's individualized attention from the consultant to the students, right? And that makes a huge difference. Again, depends on students as well as the doctor, how much they love teaching, right? And with regards to, like in Fatima's case with that cystic cirrhosis thing, crypto, whatever, I don't even know, she looked it up, right? The doctor said, ye hai, look it up. Right, and she made the effort of looking it up, and that's the case with any medical university, I'm assuming, where not many consultants are going to spoon feed you information. They're not going to spoon feed you what the situation is. You have to be eager to learn. You have to not be on your phone. You have to look it up, right? You have to go home, go to the library, and then look it up yourself, right? Obviously, if it's an obvious thing, the doctor's going to be like, oh, look at this finding under a slit lamp or whatever.
Like if there's like a hepatomegaly, they're like, sorry students are
look at how enlarged it is. Exactly.
Then everybody feels it.
Exactly. But then why? The doctor won't explain why it's enlarged or something, right? Not many doctors will, some do again. So you have to look it up. You have to be eager to learn, right?
No, if there's a finding, most of the time in JPMC, if they have like a very prominent finding, तो वो case पूरा discuss कर लेते हैं because they're like, this is something that students could. What their view is कि if there's like a very prominent finding, they'll definitely call a medical student कि आ जाओ जिसको देखने आ जाए. बाकी जो नहीं है, they're like, okay, you go away, we don't care about you. But if they show you a finding, then they most likely do tell you कि इसका पूरा case क्या है, what this patient had, what this patient didn't have, and then you can ask questions. oh, will we do this, will we do, like for example we had this one kid, उसका बहुत obviously abdomen distended था, बहुत obvious hepatomegaly थी, बहुत obvious malnutrition भी था, बहुत सारी चीज़ें हुई थी, ठीक है. And then I only took like one mock, ठीक है. It was like combined efforts. We were like 5 people on one patient. I don't know why they did that. I told everybody to split away, but चलो खैर एक बंदे पे कर लिया. And we discussed that case, and then mainly that case was about some GI problem and you know वो सब. But in the end, I was like the mid-upper arm circumference, it's too small. Like for his age, he should not be this thin. So he obviously has malnutrition. So for malnutrition, what you do is you create diet plans, you give RUTF, which is like a specific kind of food. So I asked the consultant, won't we do that, because his file and his plans didn't have that. So then she called some HOs and said कि ये भी इसके plan में add कर. So like you have to ask something, you have to be thinking.
You have to be eager and think. You have to be present in the situation and be eager
because
to
even the consultant
right?
didn't think to come to that. She was like कि हमने GI discuss कर लिया, तो maybe that's it with the case. That's all these students are thinking. When I mentioned it, she was like चलो ठीक है. पूछा.
Okay, so there's one that, and then the second aspect of learning is the variety of patients, the disease, the pathology, the investigations you see, the X-rays you see, the CT scans, the MRI, the types of patients you see, the blood reports you see, right? In AQU, I'll talk about AQU. AQU, you see multitudes of patients. Obviously, you don't see in numbers, but you see diverse pathologies. You do see, you have the opportunity to see their reports. We have a software access to all their blood works and their X-rays and their CT scans and their MRIs. But at the same time, the biggest, I think, limiting factor in a private institute, at least, is the number. I don't see if at a day the max I've seen was 100 patients, right, with my consultant. So that's probably the biggest limiting factor in terms of that.
100 is still a lot, right?
I know. Average is 20. Average is 20, 30. All right. And the thing is, other than that, I had something in my mind about reports. It was skipping my mind. What's it like there? So, well, like how many, like I'm sure you see a lot of patients, right? You see a lot of patients. You get them on
paper. They bring the entire file. Sometimes they lose their records or whatnot, but most patients do come with a file.
But then the biggest benefit in speaking from Rafi's, he went to civil hospital. He did his stuff over there. The biggest thing he would say is how it's just the number. You see numbers of patients. You'll see 100 patient with anemia, 100 patient with this disease, that disease. Whereas in AQ you'll see maybe 2, right? And it came to my mind. The cool thing is with a private institute, especially an institute like AKU, is a lot of the time patients come to AKU as a second opinion, as their final opinion, or they're in a very bad state where they've sought other medical options but they haven't been diagnosed properly, or they haven't been feeling better. That's why they come to an institute like AKU and hope for the best, right? So in that situation, you see a lot of severe cases. You see you see extremes, and I'm sure the same is in government institute.
They come at the very end.
Yeah, obviously. But then people, it's a very interesting situation here.
I think that's the case with any tertiary care hospital. They do come at the end after going to multiple secondary centers and district health offices. Yeah. Any tertiary care center, you will see people coming at the very end, at the very worst situation. Yeah. Maybe initial stages में AQA जिना की OPD नहीं आता.
Agreed. Yeah, and the third part of the video, and third and final part of the video, is how we were talking about the ability, the permission to interact with patients, to use equipment, to do practical stuff, to take histories. Like how much does it differ, right? That was the question, right?
I think it's equal. I think the only place where it would differ is inpatient. Okay. I think inpatient AQ students don't do a lot. From what I've noticed on rounds, you don't do a lot. But inpatient in a government setup, you can go to the
bed and do whatever.
And be like, Salaam alaikum, मैं doctor. बताएं सब कुछ, सारे सफाने हयात बताएं, रिपोर्ट दिखाएं, खड़े हुए हैं, इधर दिखाएं, हाथ ऊपर करें, यूं करें, यूं करें, यूं करें.
I mean, you could do that here as well, but then obviously you're not the only one there, right? There's an intern, there's a resident.
No, you can do it completely alone in JPMC.
यहाँ पे you could do it alone. I mean,
Because the thing is, I'll tell you
nobody's
why,
stopping
in
you.
a private, यहाँ पे ना you have rooms where there's like rooms and वहाँ दरवाजा बंद होता है and everything, and so you have to knock into a room, you have to go into and seek permission. In JPMC, it's like a ward, right? It's just a room with bed. Nobody's gonna stop you. You just approach one bed, बातें करने शुरू कर दो. So that's one thing. अच्छा, one thing about reports I do want to mention is that in JPMC and NICH, from what I noticed, is that there were a lot of tests that we just don't do there because we simply either don't have them or we don't have the facility, or we sign it. We say कि जैसे semen analysis होता है वो आता है एक में. If you have to do like cystic fibrosis का chloride test, it comes to AK. If you have to do histopathology, वो तो आती है. We'll take out the sample, but we'll tell the patient ये आप खान की laboratory ले जाओ. वो वहीं जाता है, वहीं से आता है. यहाँ पे because it's within their system, they do it. So ये मैं कहूँगी कि facilities do differ, and that does matter on some level.
But a biggest thing, a misconception at private institutes, especially such as AKU, is how people claim that medical students don't necessarily have the best practical opportunities. They're not allowed to take histories.
I don't think that's true. Now working.
I mean, it's a rumor. Rumor is a rumor, right? Where they haven't been through the system, so they don't know. We're here to educate and propagate the correct information, right? That's my mask. Yeah. So I'll be done in a few minutes. What time is it? We'll be there by 3, right? So so I was saying how it's a very big misconception. Yes, people are paying 3, 4, 5,000 rupees to see their doctors, but then at the same time they know it's a teaching hospital, and they know most definitely that they have rights. If they're not comfortable, I've had instances where the patient asked the doctor to be alone, right? So you have to respect that. You have to respect that.
That happens with us as well. I mean, people may believe that in JPMC people are aware of their rights, but that's not true. Like people do deny, people do request, people do demand, and then we do agree to them. Sometimes in some cases we'll be like, नहीं देखिए हमें ये करना होता है. We'll try and explain to them, but if they don't agree, we say okay. I mean, like if a patient wants to be around with a doctor, we can't force patients there. You can't force them.
So we it's a very massive misconception. Obviously, under the limitations of us being a medical student, we do whatever possible, which includes examining the patients, touching the patient, talking to the patient, taking
which is
histories.
Basically all of it.
We
you need to make a good history and examination. If you're doing that, then your med school is decent.
Tag random and more.
And tipgram.
Right? So so we have a lot of opportunities. It's a massive misconception, which I frankly think it's very stupid. And that's it. I think those 3 are like massive differences between the 2 different setups. Again, the video we were probably ranting on for quite some time. It's a very biased opinion.
It's entirely
it's only 2 different hospitals.
From what I've noticed, compared to NICH OPD and pediatric clinic here, like I introduce myself as a medical student. You know, a lot of people in NICH and JPMC, they go like, "Gee, I'm doctor," and like take the call because people have this conception that you are a doctor because even if you tell them you're a student, they still call you doctor. Like they know, but they still call you doctor.
We don't do that. What
but I always call myself a medical student. Abhi, I introduce myself.
I never introduce myself as a medical student.
The medical student. I'm going to take a little bit of history, and no one to this day has said no. You have to be confident.
Yeah,
confidence दिखाना होता है कि हम history ले रहे हैं.
How do we introduce yourself? Acha Alina? Come on camera. I'm not even gonna say it. What's like the standard? So this is Alina. Alina's been sitting here eating her biryani for quite some time. How do we introduce ourselves to a patient? Like, what do we say?
I usually say Assalamu alaikum. मैं फलाना की टीम के साथ.
Exactly.
आज मैं आपकी history and examination.
Exactly. That's a standard here. And if I've never been in a situation where they ask who, why, what are you?
Yeah.
But if they do, we're going to say we're a medical student, right? But I'm student, but we introduce usually ourselves as a team, a part of a team, Dr. XYZ's team, and we're here to do whatever, right? So yes, it's a long video, 20 minutes long right now. So we're gonna end it here. I hope
end it with the importance of history and examination.
history is very important.
You need to take good history. You need to take good history. If you're ignoring your clinic, whether you're in ATU or civil or wherever you are, if you're ignoring your history and you're not taking at least one every day or seeing a few patients, and if you're not going in that clinic and taking histories, then you're not doing yourself justice. It's not, I mean, ठीक है, यूनिवर्सिटी आप पे ज़बरदस्ती डाल दी गई कि नहीं 10 हिस्ट्री सबको सबमिट करनी होती हैं, नहीं ये सब कुछ देना होता है, एग्जाम में ये आएगा, whatever. But university can do as much spoon feeding as it wants, but if you're not doing it, you are going to lose out.
So yes, we'll end the video here. Fatma, thank you so much for being in the video. It's really nice talking to you. And hopefully we will upload this video very soon. Alina, do you have anything to say?
Allah Hafiz.
Sorry for keeping you waiting. And yeah, I have clinic at 3 o'clock. I have to rush now. It was really, if you guys have any questions, make sure you comment down. Follow me on @randomandmore_. Follow her at Instagram. I'll have it linked down below. And yeah, good luck. Bye. Allah Hafiz.